Okay, so I've already opened and fixed the links on the recorded lectures for eye and ear disorders, seizures, and gout. Thank you, Miss Bess Fontana, for repeatedly reminding me. Okay. Right, so whatever topics are on the blueprint, those are on the exam. Now, the reminder, these are the topics of the question. Okay, these are not, I'm not, of course, you can't see the question, but these are the topics that will help you answer the question. Okay, so questions will be on how does the patient know that they have, or how do you know the patient have macular degeneration versus retinal disorders? When we say retinal disorders, there were two. There was retinal detachment and retinal tears. Okay, both are caused by trauma. Now, don't be too narrow with trauma. Trauma also includes surgery. So if the patient, let's say, undergoes any eye surgery, for example, cataract extraction, cataractectomy, that can lead to retinal detachment as well, because surgery is trauma. Okay. And the treatment for that, for example, macular degeneration depends, because there's two types. There's wet and dry. Dry has no cure. All you can do is preserve whatever remaining vision you have with vitamins, eye vitamins. Whereas the wet type, there is medication for that, because that one, the wet type, is caused by abnormal blood vessels, which is kind of like cancerous. So therefore, there's a chemo drug used to treat that type of macular degeneration. Okay, the wet type. For eye surgery, I again have it on the recording. Now, eye surgery will use the cataract as the surgery. So pre and post-op care under cataract surgery will apply to any other surgery, because it's the same eyeball that you did surgery on. So preparations, teaching, although cataracts are only treated with surgery, there are eye drops prescribed, but however, the eye drops are not to treat the cataract, but because you had surgery. So because of the surgery, you'll be given eye drops for inflammation, antibiotics as well. Okay, so that's the purpose of the eye drops, not to treat cataracts. Okay, unlike glaucoma, when glaucoma, there's no other treatment. Well, there are a few, there are surgical treatments, but majority of people are on eye drops for life. Okay, so they'll be on 2-3 eye drops for life. And that brings us to, since that's the only treatment, then the patient needs to know how to administer, the patient and the family needs to know how to properly administer eye drops. Okay, what interval you need to observe. Okay, and then the rationale again is on the first few pages of the chapter, telling you the size of the conjunctival sac. That's why you can only put one drop for so between so many minutes, because it can't hold that much. So if you put two drops of the same or another medication one after the other, you're wasting the medication, because the conjunctival sac can't hold no more than one drop at a time. So you have to wait until full absorption before you can add another one. Plus, there's the book also mentions about blinking, tearing, and um yeah, irritation. Okay, so that also adds to the limitation, because when you put eye drops or any trauma or stimulus to the eyeball or eye structure, stimulates tearing, right? It causes tear production. So that also limits that further limits the amount of drops you can add, because your tears will wash it off. So if you put more than one at a time, then again, you're wasting the medication. Then you wonder why the patient's going blind. They're not getting the medication. Okay. So either the nurse or the family member or the patient themselves are not doing it correctly.
What's the time window?
Please follow the textbook. Well, yeah, it will, yeah. Okay. And then make sure you distinguish between, for surgery, just like when we go out in a really dusty place, for instance, the next morning, what do you notice in your eye? Let's say you were out in playing soccer, okay? So very dusty. What happens the next day when you wake up? A lot of crud in your inner canthus, right? So same thing here. So that's expected after cataract surgery or any eye surgery. However, if that discharge is extra colorful, is that expected? No. Is it? I mean, the patient had surgery to the eye. So what will that eyeball look like the next day? Bloodshot, okay, very red, very swollen, okay, very well, not really very painful, but tender, okay. However, extreme pain, of course, and again, I mentioned all these in the recording, okay, so you have to distinguish between expected, meaning harmless, harmless findings after eye surgery versus reportable or harmful findings, okay. And signs and symptoms of retinal detachment. Okay. Now, glaucoma has a lot of eye drops. So therefore, expect questions on glaucoma, which you'll see probably 12 or 13 questions on eye disorders. Um, Half of them will be on medications. Yeah, because I mean, that's all you teach the patient. Okay, so these things have systemic effects as well. Although you apply them to your eyeball, they are still absorbed systemically. Okay, not a lot, but I mean, there is still systemic absorption. So you still need to know side effects and teach the patients these side effects and especially on what to report. Um, for hearing, ear problems. So we start with hearing loss. There are two types of hearing loss. We have conductive and sensory neural. So make sure you distinguish between the two. And then how do you promote communication? Meaning you have a hearing impaired patient, how do you communicate with them, okay, effectively? And then you teach them also because the family members also need to communicate effectively. Okay. Because this can destroy relationships. Yeah. You hear something, or you thought you heard something, and then now there's a argument. People get divorced for these things. Okay. Meniere's disease. Okay. Specifically Meniere's signs and symptoms, then treatment. Meniere's have a trio of manifestations. There's vertigo, hearing loss, and tinnitus. Okay, very good. So make sure you're able to manage each one because these are three separate symptoms. Okay, so there's no one medication for all three symptoms. Okay, so they're separate, treated separately. So that's why Meniere's disease can be debilitating. Okay, people with that disease sometimes go on disability. Okay, they can't stand it. I mean, vertigo. Yeah, what can you do, right? Okay, causes of conductive versus sensory hearing loss. Um, I think this is a select all that apply. So you pick, okay, which ones will cause conductive, or it could also be sensory neural. And then ear surgery. Okay, I can't remember which disorder, but there was just like cataract, wherein only cataract has the pre and post-op care teaching. Same thing also. I think it's either stapedectomy or mastoidectomy. Uh, where is it? Okay, yeah. So that's where you'll find the teachings for ear surgery. Okay. Let's say, for example, don't get the ears wet, meaning you'll put a cotton ball plug there. Okay. Wear a shower cap, okay, because you can't get it wet. Okay, of course, you can't go on a pool. There's restrictions also with cabin pressure, so you can't fly on an airplane for a certain period of time. And then if there are eye drops, then there's also ear drops administration. Okay, so this is you or you're teaching the patient how to administer. So similar to, I think I mentioned this in the recording for bronchodilators, MDIs. So patients, MDIs and also DPIs. So most patients, if you observe them, especially the elderly, You observe them, administer, because some of them will grab the inhaler from you. Okay, I'll do it myself. And then you observe them, they don't know how to do it. An old timer go, or yeah, doesn't make any sense. And then of course I tell them, sir, you're wasting your medication, and no wonder you're here. Okay, so teach them. Okay, so same thing here for eye. Remember, for glaucoma, for instance, these medications keep them from getting blind. Okay, so therefore, if they're not doing it correctly, they'll go blind. This one specifically vertigo, as separate from Meniere's, but management really is the same. Okay, so vertigo is always manifested by dizziness and nausea, vomiting, right? Okay, so that's the most debilitating part of it. Also, besides ear drops, there's also ear irrigation. Okay, and then nursing care. Again, how do you approach people who can't hear, who can't see? Okay, so there's techniques. Okay, how you, yeah, which side you're going to approach them, what the tone of your voice is, right? So the lighting, all right? So there are specific, they're in a nice chart. Okay, difference here is this is now an eye ointment. Okay, so if you're going to administer both an ointment and an eye drop, which one will you give first? Why eye drop? Okay, because remember, any ointment is what is the base of an ointment? Wax, right? Yeah, they're always made of petrolatum, right? It's always petrolatum when you say an ointment. So therefore, if you put an ointment first, then the eye drop can't go through the oil anymore. Okay, so this one, if you see multiple topics which are the same, let's say here, care of a patient after ear surgery and then eye surgery, that means that's multiple questions. Okay, meaning this one may be for eye and ear, and then you'll see it here again. So that means there's multiple questions. And here again, specifically stapedectomy. Okay, so same thing as eye surgery. This one is ear surgery. Glaucoma. Okay, so teaching, and then especially on the medications, the eye drops. For gout, this may be a very short topic, but there are at least 7 questions. Okay, I think I counted 7 questions on gout alone. Most of them on medications, diet, and client teaching. But I guarantee there's at least 4 medication questions on gout. So colchicine, allopurinol, what? Pegloticase, and there's one more. Yeah, that's a pain. Yeah, that's a NSAID. Yeah, I mentioned that. Okay. When you say diet, and symptomatic management, see here it says farm and non-farm interventions. Now there are interactions, okay? There are medications you need to avoid regarding gout. Okay, one of them was aspirin and a certain type of diuretic also. Okay, very good. Okay, that's for gout. Now for epilepsy and seizure disorders, what's the difference between seizure disorder and epilepsy?
It's happening all the time.
5 minutes.
5 minutes.
Right. 5 minutes, no?
Epilepsy happens more than once, like in every six or
Actually, okay, let me clarify that, okay? Okay, so when we say seizure, you can have multiple seizures, okay? So it's not really the defining distinction, okay? So if you have a seizure and then we can identify the cause of the seizure, which is let's say drug and alcohol withdrawal, or you have some brain tumor, or you had a really high fever, a severe metabolic acidosis, or let's say severe uremia, DKA, okay? So, or other toxins. If there's a cause of the seizure, it's not epilepsy. You can have 1,000 seizures, okay? But each time, if we can identify a cause, you have a seizure disorder. You don't have epilepsy. It's epilepsy if you have more than one, which we do not find any cause at all. We did all the MRIs, all the blood testing we have. Okay, specialist has seen you. They can't see a cause of the seizure, meaning there's nothing provoking the seizure. Unprovoked seizures, you have epilepsy. Okay, and then the only treatment for epilepsy, of course, is anti-epileptic medications. Okay, you'll be on it for life. Seizures, of course, will still give you anti-seizure medications, but will also, because we know the cause, then we will have to treat the underlying cause. So for instance, you have a brain tumor, then we'll have to treat the tumor. Does that make sense?
Yeah.
Okay, so that's the difference between the two. Okay. So this is, since nothing here except medications, so a lot of medication questions. Okay. And I specifically highlighted which medications will be on the exam. They were highlighted in yellow on the recording. Okay. The ones that you'll see on the exam. Because that table is very long. If there's anything you want to remember, just keep in mind anti-seizure medications, anti-epileptic medications are just like hormones, like steroids or thyroid hormones, beta blockers. You cannot stop these. Okay, so if the patient has a medication, if they're on them, actually not even taper. Let's say the patient's NPO, correct? So for whatever reason, maybe they're unconscious, okay? Because not all of these medications have an IV form. So some of them are strictly capsules or tablets. So the doctor has to know. That way they can give you another one. But at no way should these be stopped abruptly, because this is one cause of, what's the emergency? Status epilepticus, which is defined as, okay, seizure lasting more than 5 minutes. So what do? Someone seizing, we'll just time and then say, okay, let's see. It's not 5 minutes yet. Okay, we're still 4 minutes in. So what do when someone is seizing in the hospital? You have to stop it. Okay, so you call, yeah, usually call rapid response, and then doctors will come. They will order. What are those two medications? Stop it. Lorazepam or diazepam. Okay, so two drugs to stop. You have to stop it. Again, what's the reason? Why do we have to stop the seizure? To prevent brain damage. Okay, because it could be status epilepticus. Do we wait until 4 minutes and 58 seconds? Okay, it's not 5 minutes yet. There's no brain damage yet. Okay. Oh, now there is. Okay, 5 minutes. Okay, give the. Okay, so it's too late, right? So we always. Okay, we have to interrupt the seizure. Okay. And then of course, what to do before, during, and after the seizure. Very nice chart for that. Okay. And then I also asked in the recording, what are the 5 things you need to have? So when the doctor orders seizure precautions, so make sure you have those 5. All right. Do we need an order? No, you know the patient's under seizure, has history of seizure or has conditions that could lead to seizure. Initiate it. Yeah. Do you need an order to set up a suction and oxygen? No, because you're not giving it. You're just setting it up. Do you need an order to put in an IV? No, that's protocol. Every hospitalized patient should have an IV access, right? And should the bed be low and locked? Yeah. Okay, you don't need an order for that. Okay.
The rails.
Adding side rails, just follow agency policy, because now there are hospitals that do not do that because they don't want to label the patient, because people will see, oh, the side rails are padded. Oh, this seizure boy. Okay, so they don't want that stigma. So again, follow agency policy. But yeah, padded side rails, yeah, we should do that. But again, just be careful where you work, okay? Because sometimes they have policies against it. Yes.
Sometimes in some places they give them something like and to wear something just like there's a fall when they're having the seizure.
Yeah, there are certain wards that are like that, certain units. Again, follow agency policy. There you go. So we had eye, ear, seizure, and gout. Okay. So let's start with the other topics. Any questions on heart failure, specifically these topics up here?
Possible, you're able to let us know roughly how many questions of those.
Rather massages or compressed that were done by the doctor.
Yeah, but you're there.
Okay, that's what we need to know for that.
Yeah. You know, the vagal maneuvers.
Just like the GBA one.
Okay, so somebody asked how many questions? Well, it's evenly distributed. Just know though that the three new topics, seizures, eye and ear, gout, will have around 30 questions.
Okay.
30, maybe 35. Okay, because there are many medications. So 35 alone for those topics. So that means 65 will be distributed among the other topics. Okay, so that's distributed between the cardiac, which includes heart failure, dysrhythmias, then the valve disorders, endo and pericarditis. And we have for the presentation only these two. So only
Oh, the
DIC. Well, each bleeding disorder, so it'll be all four. So DIC, ITP, hemophilia, and HIT. Then for the endocrine, we got DKA, HHS, also hypoglycemia. Then we have thyroid and parathyroid disorders.
What is that? Oh.
ABG, welcome to the ABG interpretation.
You don't know how to do ABG? Yeah, that means you'll be given an ABG.
Closing removal of car.
No, it's probably one question on ABG because I only see it once, so that's one question.
So roughly, that's how many questions are there?
Yeah,
So there's 100 lines there?
Yes, 100 something over like.
more or less.
We go over 100.
I don't think it's 100, but remember, there's multiple questions on the same topic. Yeah, this is not 100. This is probably
Like 150. No, that's because remember lines, it'll say signs and symptoms, risk factor, like
Right.
for CKD, so it's multiple things in one line, so. All is probably gonna be just 150 lines. Oh.
Then we have a dosage. Is there dosage?
one, maybe two.
Okay, I can live with that. Oh.
That's why I don't put too many dosage questions is because on the NCLEX, you'll be lucky to get one. Okay. I mean, it's on the NCLEX, but the NCLEX is not a dosage exam, okay?
Mostly it's a safety. One.
Oh, yeah.
Wait, let's try to do 5 seconds.
Oh, okay.
Sorry.
Where?
Just going over there.
We didn't discuss hypophysiectomy.
I don't think I've ever had that.
So this is under the causes of SIADH and diabetes insipidus, which is brain surgery. Okay.
Yeah.
So let me discuss hypophysiectomy really quick. It's really easy. When we say hypophysiectomy, this is referring to hypophysis, which is the pituitary gland. So the pituitary gland is called the hypophysis. So hypophysiectomy is the removal of the pituitary gland. Now, 9 out of 10 approaches is through the nose. We call that transsphenoidal hypophyseectomy, meaning they'll remove the tumor and of course the pituitary gland as well through the nose. As opposed to open, skull surgery that's very invasive. No? So least invasive would be, we'll do it through the nose. So they'll put several instruments through your both nostrils. Of course, you have to be intubated for this. However, in order to reach, they'll need a third opening. They'll make an incision in the roof of the mouth, just one small incision to put more instruments through. Okay. So even though we went through the nose, where did we go? Into the brain, right? To get the tumor or the pituitary gland. So it is brain surgery, no matter how you think about it. So therefore, do you assess the neurologic function
Yes,
afterwards? Yes. And will there be a possible leaking of CSF? Yes. Okay. So expect after surgery, the patient will have nasal packing.
Yeah.
Right? So tight nasal packing. So can they breathe through their nose? No, they'll have to be mouth breathers for at least 2 days. So it's a tight packing. And of course, is the drainage going to be clear or bloody?
Bloody.
You expect it to be bloody. And how do you know whether something has a liquid coming out, has CSF or not? What does CSF contain? Glucose. Okay. Now, does blood have glucose?
It does, but not that much.
It does.
Yeah.
When you check blood for glucose, it will show you glucose. Therefore, so is the glucose testing reliable
No.
to check whether or not the drainage coming out is CSF or not?
No.
No. So we can't do glucose testing to test for the presence of CSF. What we'll do is a very primitive method. We'll just dab it with a dry piece of white gauze. And then if there's a yellow ring around the blood, that's called a halo sign. And that means there is CSF in that drainage. Okay, very primitive, but very effective. Okay, so you just dab the drainage and then observe it after a few minutes. If the red circle has a yellow border around it, that's CSF. Okay?
So that's how effective fluids and electrolytes, so what will be low and what will be high?
No,
So it's
that what I'm discussing is simply to test for the presence of CSF. That way you can report it to the doctor that there's a leak. Okay? Because that's dangerous. Okay. Others are, of course, again, the eye, the ear, and the brain are all inside the same skull, correct? So therefore, pre and post-op, will they be different? Very similar. So activities that are restricted or prohibited include anything that causes you to hold your breath. So what activities cause you to hold your breath? Anytime you push or pull. Any activity that involves pushing and pulling. Because in order to push, what must you do? Can you push if you're exhaling? Then you have to hold your breath, right? You have to inhale and hold your breath and push. No matter what, if you're pushing turd, pushing a car, or let's say pulling something, okay? So you're still holding your breath. So what about holding your breath increases intraocular, intra-auricular, or interauditory or intracranial pressure?
Yeah.
Why? How does holding your breath do that?
Your body senses you don't put oxygen.
Nowhere to go.
Okay, so what happens if I take a deep breath and hold it? What happens to intrathoracic pressure? Increase or decrease? Look what I just did.
You're holding it tight.
What happens to intrathoracic pressure? Increases. What happens to the heart in the middle? The two lungs are squeezing it. What happens to venous return? Venous return. It decreases venous return Okay, because you're squeezing the heart, so there's less blood coming from
From the brain.
the
That's
head.
why you need to do CPR to push oxygen to the brain. And
Well, everywhere, yeah.
otherwise,
Yeah. But anyway, so holding your breath, actually, that's why, which brings us back to incentive spirometer. How do we use the incentive spirometer?
You inhale.
Slow, fast,
Slow.
and deep, right? So how often do you do it?
They say 10 times an hour.
10 times every hour, which is every how many minutes?
Every 6 minutes.
Once every 6 minutes. Why?
The inhale.
The same rationale. Because if you're doing this exercise like several times in 1 minute, what will happen? I challenge you, try inhaling like,
I've done it and stuff.
yeah. So let's just do it 5 times. Okay, who wants to do it? Inhale deeply 5 times consecutively. It's not headache. You get lightheaded. You're gonna pass out. Why? What happened? Why do you pass out? You increase intrathoracic pressure. You decrease cardiac output because you're squeezing the heart. So cardiac output drops. So patient will pass out. That's why we tell them to use the incentive spirometer how often?
Every 6 minutes.
Once every 6 minutes. Never tell them to do it consecutively. Because you think they'll keep doing it if they pass out? No, I don't like this anymore. Yeah. I don't like this. All right.
Professor, so it's the
Yes.
same rationale for vasovagal.
Well, vasovagal is think of vagal stimulation as when you're vomiting, which still, yes, there's some holding your breath there. But the vagus nerve, right? Runs from your mouth, from your lips actually down to your rectum. Okay. So activities that will stimulate that is again pushing. Okay. So any pushing activity, say you're blowing a trumpet, for instance, or
Getting an IV, like a lot of patients, when I used to assist the nurses.
well, yeah, because
Just
they
pass
hold their
them
breath
with
too.
the-
Yeah. So anytime they hold their breath. Unlike that. Okay, so she's breathing very well. So that's wonderful. Any other question? So for immunity, that's RA, myasthenia gravis, plasmapheresis. Oh, we have blood transfusion. So for the calculation, I think it's on the fluids for DKA, fluid administration, or maybe insulin dose, one of those, or maybe both.
One point after each.
Yeah.
Professor. You wanna ask it out loud? Professor, can we ask the question? So on the exam, City got the question about what was what the most telltale sign for DKA? You had like arterial.
Okay, remember the textbook said no, it's not confusing. Textbook clearly says that DKA glucose can be 250 to 1000. Yeah. And then next statement says the severity of DKA is not based on the glucose, but on the ketones, the pH level. Yeah. So therefore, you can't diagnose DKA based on the glucose. Yeah, because somebody could be 300, but then the pH is normal.
That's just hyperglycemia.
Yeah, so therefore your basis is the pH,
So that pH.
not the glucose.
But I thought that.
pH is normal there. No, higher.
No, the
higher
pH
here.
pH was 6.9.
6.9.
No, the pH was 6.9 and the bicarbonate was 19.
90. So the answer is bicarbonate?
Or pH.
pH.
Yeah, pH was 6.
Yeah, it was low, which is accidental.
Good job, Tyler.
Anyway, maybe that's on the DKA question again on the final.
I thought that was. That's 6.8, you're not even having the
Any other question on the blueprint lecture?
You're not 505.
The class 3 heart failure, which one was that one?
The one with
The
the physical
simple-
activity.
Oh, yeah, we did say that.
So it's, hold on, hold on. So isn't it at 6.8 though, you're like no longer viable for life? Isn't that 6.8? Like the, on the extreme. of the
What's your
50.
point?
No, I'm just saying,
For the
that's the
pH.
number where you're like no longer valuable for life. Is that
I've
like a
seen,
parameter?
I've seen them alive at 6.5.
6.5, okay, so there's not.
I mean, they're not unconscious, but they're alive.
What were the symptoms for dehydration? Cooler, pale, or dark and concentrated urine?
Urine.
Dark and urine?
Yes.
I feel like I was thinking hypoglycemia, like cooler, pale.
So let me give you a
I was
paper.
thinking of
Let me
hypoglycemia.
give you a paper.
Yeah.
All right, so you take a short break for those who need to read.
Oh, we talked about it, Don?